one of the live cases where IBUS and OCT are going to be simultaneously acquired and simultaneously displayed. This is increasing the amount of information. The scaling point is that the imaging catheter, when you are combined, are becoming a little bit bigger, and that is could be an additional point of challenges when we are dealing with a complex patient like what we are dealing every day. So it's a point of refinement, it's a point of bringing the data. I think one of the most important is there are few people around the world, especially Western Europe and US, using imaging and in very discretional way. So there is a big difference between doctors and between hospitals, and that cannot exist. So we needed to have the evidence, and we needed to have more adherence, especially to guide complex intervention, likewise we are dealing today.
So to be the great or good operator for the in-situ intervention, maybe I think that it's a very important point is to the accurate guide wire manipulation. So there are several techniques, reverse cut technique, retrograde approach, and the ADR, but the bottom point is the accurate guide wire manipulation. So the tip to the guide wire torque is 140 centimeters away, but you should control the guide wire accurately and direct the guide wire target at the target, like this. So that is the initial first point. Then move to the retrograde approach and also the ADR. So I think that is a very important point, and accurate guide wire manipulation.
Prevent the complication after the intervention through radio transradial access. I think more important is preoperative management and assessment. As a PN nurse, we have to assess the transradial access site before the procedures. Actually, we will do the Allen test before to see whether the under artery and also the radial artery is patent. Is yes, positive, then we will inform the doctor. You can proceed the procedure through the transradial access. After the procedure, we also have to closely monitor the radial access site to see whether there is hematoma or any dissection. So we will do the assessment by oximetry monitoring hourly, and also see any swelling. If the wound is okay, we will remove the access device and then do the simple dressing. And also after the procedure and the patient back to home, we will also advise the patient to not to do the healthy exercise and to take up the very healthy object in the first week in order to prevent any strengthen the strength over the access site. And also we will advise the patient not to wet the transradial site for 1 to 2 days in order to prevent any infection. So if also we will advise the patient to alert the healthcare profession. If there are any swelling, wetness, and also even the fever, they have to come back to hospital at once to see whether there is any infection. I think this is my experience over the past few years that I can advise even the younger interventionalists and also the nurses as well.
So in Asia, we have a data, so it's quite common in young ladies, premenopausal, about 0.5%, in overall of the STEMI patient. But actually in premenopausal, that will be like 40%. And actually for the data in Asian, we have a really scarce data because there's no database, adequate database, and mostly it's a retrospective. And you asked me that whether the man, because that's like sometimes it's 60%, 40%, but later we have a new data that for the SCAD, only 10% were men, and actually men have a different of a natural history as women. So men with the SCAD will be younger, no emotional stress, and actually relate to the physical stress, like if you do the heavy exercise. So maybe you have to be really careful to do weighting.